Well, and the question is, should it be treated without thrombolysis? Does thrombolysis provide any added value to embolectomy in patients with large vessel occlusions? This is a controversial topic, and there are trials that are now in planning, and hopefully we'll get some answers from these trials. Clearly, there becomes a point in terms of accessibility to an endovascular center where intravenous thrombolysis, just like in cardiology, is recommended because patients don't get to the endovascular center early enough, and the delays justify giving intravenous TPA first with a hope that the vessel will recanalize, albeit at a lower rate, but there is a chance that the vessel recanalizes. And one of the big questions is where is this inflection point in terms of time or distance to an endovascular center. In cardiology, for instance, the recommendations are that if the patient cannot arrive within 2 hours to a cath lab, then patient should be treated with thrombolysis. Hopefully we will work these kind of things out in stroke as well. It's likely that this time window is going to be probably shorter for endovascular stroke therapy, but there probably will become a certain inflection point beyond which TPA is beneficial, and within this time point, we need to figure out whether TPA really does provide any additional value to treatment. Now, there are certain categories of patients who benefit more or less from intravenous TPA, and I think that the other approach is to address the value of TPA in these patient populations. For instance, we know from the large the randomized trials that were published last year, and also from the IMS3 data that strokes due to occlusion of the internal carotid artery, whether it's in the neck or whether it's in the brain, are associated with very poor response to intravenous TPA. For instance, in IMS3, patients who had any kind of carotid occlusion and were treated with intravenous TPA had only 5% good outcomes. And so that begs the question, in this particular category of patients, does IV TPA do anything beyond placebo, beyond no thrombolysis? And I think, for instance, for this group of patients, that would be a good opportunity to study whether intravenous TPA should be given regardless of distance or time, because it's not that clear that there's great benefit from treatment with intravenous TPA. And furthermore, if you, for instance, have a carotid occlusion in the neck and you need to put a stent in the vessel to open it up, if you have IV TPA on board, you're going to be your treatment choices will be limited by the fact that you have intravenous TPA on board. You can't use dual antiplatelet therapy, and so on and so forth. So to me, the low-hanging fruit in terms of addressing whether TPA has a role anymore in large vessel stroke would be carotid occlusion. As a stroke neurologist that also treats patients with intravenous TPA, I can tell you I have seen many patients who have recanalized very fast with intravenous TPA, especially more distal occlusions, even M1s, especially distal M1s. There is good response to TPA. The question is TPA of any benefit? Is it neutral, in which case we worry about cost, or is it harmful over and beyond endovascular therapy? But given the fact that we know that TPA opens up M1 occlusions about 50% of the times, I think that a study that would compare endovascular therapy with intravenous TPA in the in the M1 occlusion population would probably require a lot of patients to give us an answer. There are trials that are powered as non-inferiority, but the fact that endovascular therapy is going to be shown to be non-inferior to IV TPA doesn't mean that we shouldn't be using IV TPA. So to me, a more useful trial would be to show that TPA is either inferior to just direct intravenous to direct embolectomy, or that the combination is superior. That I think we would learn a lot from such a trial. But the problem with these kind of trials is they're limited by a very large number of patients that would have been that should be enrolled, except for perhaps the population of ICA occlusion, where, in my opinion, we would have a low enough sample size to show that perhaps endovascular therapy may be the way to go, and answer the question of whether one approach is better than the other. In the case of stroke, of course, we don't know in the field. The patient doesn't know if they have a hemorrhage versus an ischemic stroke, so it's even more complicated. But yes, I mean, as you mentioned, more and more patients are going to be treated. To me, that's the challenge now, and I think it's something that's emerging also from this meeting. We've proven that this treatment works. That was last year's topic at this meeting. Now the challenge is to get this treatment to as many patients as possible within the shortest period of time, so that we get the best possible outcomes in a larger segment of the population. And then these kind of questions of IV TPA versus non-IV TPA, in my mind, these are kind of secondary, if you want, or the technique that we use. I mean, they all work very well. We've seen that. There are some differences, but these differences are relatively minor. The same thing with IV TPA versus direct to endovascular suite. To me, it is an important question. But the most important question is, how do we build the systems of care around endovascular stroke therapy so that we can treat as many patients as possible who benefit? That is the big challenge.